My name is Dr. Min Hai Tran, and I am a neuroanesthesiologist, assistant professor at the University of California, San Diego. I will be talking about neuroanesthesia and a pregnant patient. Key concepts to be covered in this talk include the fact that neurosurgery during pregnancy is rare. However, elective neurosurgery should be postponed until after pregnancy and delivery. Emergency surgery, however, should proceed immediately. For urgent but not emergent neurosurgical cases, these should be scheduled ideally during the second trimester. Indications for perioperative fetal monitoring will be based on gestational age, fetal viability, and the ability of personnel to interpret the data. Pregnancy has significant physiological effects on multiple organ systems. The physiological changes of pregnancy must therefore be considered. And overall, no anesthetic agents have been proven to be teratogenic. However, many agents do cross the placenta and can result in neonatal depression if delivery is imminent following the neurosurgical procedure. The optimal way to provide for fetal safety during neurosurgery is to maintain adequate maternal oxygenation, ventilation, and perfusion. So looking at the physiological changes of pregnancy, in the cardiovascular system, cardiac output will increase, and this is due to an increase in the stroke volume, 25 to 30%, as well as an increase in heart rate to 15 to 25%. Echocardiography will demonstrate an eccentric left ventricular hypertrophy with increased ejection fraction. Blood pressure, however, remains normal or slightly decreased, secondary to reduced systemic vascular resistance. Cerebral blood flow and intracranial pressures, however, do not change. Of note, aortocaval compression of the inferior vena cava can cause hypotension in the supine position, and therefore must be considered during positioning of the patient under an anesthetic. The pulmonary and respiratory systems and the airway. Of note, potentially difficult airways or difficult intubations may occur in pregnancy, secondary to airway edema. Ventilation will be increased, secondary to increased tidal volumes, and this will cause a mild respiratory alkalosis. There will be a decrease, about 20%, in the functional residual capacity, and with the increased oxygen consumption during pregnancy, this will contribute to a rapid oxygen desaturation with apnea. The respiratory alkalosis of pregnancy can be demonstrated with a PaCO2 at around 30 millimeters of mercury. With this, there will be a compensatory decrease in bicarbonate to about 20 milliequivalents per liter. The average pH of a pregnant patient is around 7.44. And hence, under anesthesia, ventilation should be targeted at a PaCO2 of 25 to 30 millimeters of mercury. In the hematological systems, there will be expanded intravascular volumes, and this is both with an increase in red blood cells as well as plasma volume. Since plasma volume increases much more than the red blood cell volume, you will see a dilutional anemia. Plasma albumin is also diluted, and with that, a decrease in oncotic pressures. This decrease in oncotic pressures will predispose to edema. In the setting of brain injury, low serum osmolality can negatively influence brain swelling and therefore contribute to further increases in intracranial pressures. Perioperative fluids should ideally be isotonic to prevent further brain edema. Pregnant patients are hypercoagulable, and hence you will see elevated fibrinogen and factors 7, 8, 9, 10, and 12. In the gastrointestinal system, there will be decreased lower esophageal sphincter tone, which increases gastroesophageal reflux and hence aspiration risk. If patients are more than 20 weeks gestation, they should be considered a full stomach and have a rapid sequence induction. Liver size and liver blood flow do not change, and there is little change in liver function, synthetic function. However, of note, pseudocholinesterase activity will be decreased about 25%. However, this is not clinically significant. There will, however, be increased insulin resistance, and this will predispose towards gestational diabetes. And this can also make existing diabetes much more challenging to manage. In the renal system, renal blood flow and glomerular filtration rate will increase. This means that creatinine clearance will increase with a resultant decrease in serum creatinine levels. The increased GFR can also affect the clearance of other medications, in particular the anti-seizure or epileptic medications, and hence their dosages may need to be increased during pregnancy to reflect this faster clearance. In the nervous system, the MAC values, or minimum alveolar concentration for inhaled anesthetics, may decrease, and hence pregnant patients are deemed to be a little bit more sensitive to volatile anesthetics. They are also more sensitive to local anesthetics, and spinal and epidural dosing is usually reduced. The autonomic nervous system definitely plays an enhanced role in blood pressure control during pregnancy, and hence when sympathetic blockade occurs by a general or neuraxial anesthetic, profound hypertension may ensue. Now to some anesthetic considerations related to the physiology of pregnancy. Of note is positioning. Patients who are more than 20 weeks gestation should be left in a left lateral position, which will allow for uterine displacement to avoid venal cable compression. Pre-induction, patients should be optimally positioned for a tracheal intubation as there is an increased risk of a difficult airway, as noted previously. During induction and airway management, as patients have decreased functional residual capacity and high oxygen consumption, rapid desaturation can ensue. And so, adequate pre-oxygenation is vital and essential. Again, if a patient is more than 20 weeks gestation, a rapid sequence induction should be definitely considered. In the setting of increased intracranial pressures, the anesthesia provider will have to balance the aspiration risk versus the possibility of hemodynamic instability with a rapid sequence induction. Here is a schematic which shows, on the left-hand side, a supine patient and the fetal sac falling down against the bony prominence of the spine, which causes compression of both the aorta and the inferior vena cava. If pregnant patients that are more than 20 weeks gestation or in the third trimester are tilted to the left about 15 to 30 degrees, as you can see in the schematic on the right, the aorta and the inferior vena cava are no longer compressed. Coming now to some of the drugs used in pregnancy for anesthesia. Both propofol and etomidate are common induction agents. Propofol dosing is unchanged during pregnancy. Propofol itself is rapid onset and will decrease your cerebral blood flow and your intracranial pressures, but remember, it will also cause hypotension. Etomidate will maintain cerebral perfusion pressure, but it will not blunt your hypertensive sympathetic response to laryngoscopy and also may cause myoclonic movements. Anesthesia providers must be prepared to maintain hemodynamic stability during induction, regardless of which agent is utilized. Also, considering the potential for difficult intubations with pregnant patients, backup airway management equipment should be readily available and plans instituted before induction. Maintaining maternal and fetal well-being under anesthesia is definitely a balancing trick. No anesthetic drug has been proven to be teratogenic at clinical doses, and to avoid intrauterine asphyxia, maintenance of adequate oxygenation in the parturient is vital because prolonged hypoxemia will lead to fetal hypoxia and acidosis. Ventilation should be targeted at normal capnia, and remember, for a parturient, the PaCO2 is around 30 millimeters of mercury, which is a relative respiratory alkalosis. Hypoventilation and maternal hypercarbia can cause fetal respiratory acidosis. Hyperventilation with increases in uterine artery constriction, will end up decreasing placental blood flow. Hemodynamic goals should be determined in conjunction with neurosurgical teams to maximize the cerebral perfusion pressure and cerebral oxygenation. And consideration must be given to significant hypotension below baseline should be avoided, as uterine perfusion is very dependent on the maintenance of adequate perfusion pressures. No anesthetic agent has been shown to affect long-term neonatal outcomes, as many do cross the placenta and may cause transient decreases in fetal heart rate variability, but this reflects an anesthetized fetus without any evidence for any long-term effects at this stage. However, if a cesarean delivery is immediately going to precede neurosurgery, it would be prudent to limit the volatile anesthetic to 0.5 Mac or less, as volatiles are known to be potent uterine relaxants and may promote uterine atony, which will lead to increased risk of bleeding. During emergence from anesthesia, the primary goal for neurosurgery is a smooth, rapid emergence to allow a quick neurological evaluation. Keeping in mind, in our pregnant population, there's increased sensitivity to anesthetic drugs. Again, when you're more than 20 weeks gestation as a pregnant patient, you do have increased risk of aspiration. So, in a pregnant neurosurgical patient, the endotracheal tube should not be removed until the patient is awake, strong, and following command. If reversal of neuromuscular blockade is done with neostigmine, please consider giving also atropine rather than glycopyrrolate to mitigate the acetylcholine-mediated bradycardia, as atropine and not glycopyrrolate will cross the placental barrier. Sugammadex has not been extensively studied in pregnancy, though there have been some case reports in animal studies which have not shown any teratogenicity, and this drug has minimal placental transfer. For a pregnant woman who experiences intraoperative hemodynamic catastrophe or cardiac arrest, standard ACLS protocols should be followed. However, there will be priority given to maternal treatment and survival. Of note, chest compressions, although done in the supine position, should be done with manual left uterine displacement or a left tilt of 15 to 30 degrees. And if spontaneous circulation does not return within 4 minutes of chest compression, please consider fetal delivery via cesarean section. This early delivery will help offload the inferior vena cava and improve venous return for the mother and her chance of return of spontaneous circulation. The obstetric teams therefore should be notified at the first sign of maternal hemodynamic compromise. Electrical cardioversion and defibrillation protocols are not altered in pregnancy. With proper pad placement, the current that passes through the fetus will be minimal. Now we will talk about common neuroanesthesia drugs in the pregnant patient, which include mannitol, loop diuretics, steroids, and anticonvulsants. These medications may be utilized to enhance the operating conditions for the neurosurgeon, reduce intracranial pressures, or provide seizure prophylaxis. The anesthesia provider must be aware of maternal and fetal effects of the delivered drugs. Mannitol is an osmotic diuretic that is administered to reduce intracranial pressures. It may contribute to fetal dehydration, hyperosmolality, and electrolyte imbalances. Given this, a reduced dosing of mannitol of 0.25 to 0.5 milligrams per kilogram is suggested for pregnant patients, in comparison to the 1 milligram per kilogram that is sometimes used for non-pregnant patients. Loop diuretics such as furosemide can cause fetal electrolyte and fluid imbalances. Both mannitol and diuretics can cause hypotension, which may lead to decreased uterine perfusion. Steroids, which are commonly given to reduce cerebral edema, is usually considered safe in pregnancy in the doses normally used, and if it's used for a short period of time. With the anticonvulsants, For patients that are long-term therapy, consideration must be given to increasing these doses to reflect the increase in drug clearance renally. For a one-time intraoperative dose, levetiracetam or Keppra is efficacious and safe in the pregnant patient. Please refer to Table 2 in the book chapter for a more comprehensive list of anesthetic and perioperative drugs and their safety profiles in pregnancy. Now we will discuss intracranial procedures in the pregnant patient. Intracranial hemorrhages. This may be secondary to aneurysm rupture or a bleeding arterial venous malformation. The incidence of intracranial hemorrhages is about 10 to 50 per 100,000 deliveries and accounts for about 7% of pregnancy-related mortality. The risk of subarachnoid hemorrhage is increased with uncontrolled hypertension, such as in your preeclamptic patients. Craniotomy with arterial venous malformation resection or aneurysm clipping or interventional radiology procedures may be indicated during pregnancy. Intracranial neoplasms. Brain tumors are rare in women of childbearing age, and the incidence is not affected by pregnancy. The symptoms of the tumor may be exacerbated secondary to accelerated tumor growth or edema. Meningiomas, the most common brain tumor, are notable for estrogen and progesterone receptors. The majority of brain tumors do not require acute surgical interventions until after delivery, in the absence of life-threatening symptoms or worsening neurological status. However, for patients who do have non-life-threatening symptoms such as headache and seizure, the risk of surgery should be balanced against the symptom severity to determine the optimal timing for their surgery. Patients with acute neurological deterioration who are unresponsive to medical management may require more urgent surgical intervention, regardless of the gestational age. Traumatic brain injury. In the setting of acute traumatic brain injury with elevated intracranial pressures, early protocol-based resuscitation is standard of care. Surgical intervention to alleviate high intracranial pressures from hemorrhage or cerebral edema should not be delayed. Aggressive management of maternal hypotension is essential to preserve cerebral and uterine perfusion. Intracranial pressures reducing measures such as mannitol and hypertonic saline should be given when appropriate. And again, ventilation should target a PaCO2 of 25 to 30 millimeters of mercury, as pregnant women have a primary respiratory alkalosis. Spine surgery during pregnancy is usually rare and is actually reserved for cases of very progressive or severe neurological deficits. In emergent situations that are pending permanent neurological injury, surgery in this situation should not be delayed. Back pain itself is extremely common in pregnancy, but the incidence of asymptomatic lumbar disc herniation is actually rare, about 1 in 10,000. In the cases of disc herniation, the severity of symptoms will guide management. If symptoms are mild and non-progressive, conservative treatment until delivery would be advised. The gravid abdomen presents a very interesting challenge for the anesthesiologist and the surgical team when it comes to positioning. It is essential to keep the uterus free from pressure and compression. So given that, the lateral positioning is the preferable position. However, if prone positioning is required, it is paramount that the abdomen be kept non-compressed. A four-poster laminectomy table supports the sternum and the anterior iliac spines, leaving the gravid abdomen free from pressure, may actually be employed. Interventional radiology during pregnancy. Cerebral angiography may be indicated for diagnostic workup or treatment. For subarachnoid hemorrhages secondary to aneurysm rupture or AVM, coiling and staging is absolutely preferable to craniotomy. Consideration should be given to optimal timing for non-emergent cases, patient positioning, and perioperative management. Interventional radiology procedures carry additional radiation risk to the fetus. So wherever possible, minimizing the degree of radiation would be advised. Try to utilize ultrasound or MRI. Try to keep fluoroscopy at a minimum. And for intracranial procedures, fluoroscopes should be tightly focused on the head to reduce the radiation scatter and abdominal exposure. And even though a lead apron over the abdomen does not provide significant protection, it may be beneficial for peace of mind in an awake patient. The type of side effects related to radiation is based on the gestational age. So during very early gestation, up to 2 weeks, spontaneous abortions may occur. From weeks 3 to 8, during early organogenesis, radiation poses a risk for teratogenicity and structural abnormalities. From weeks 8 to 15, there may be diminished IQ or mental retardation. And then after 15 weeks, the damage to fetal cells increases the risk for childhood cancers. Timing of neurosurgery during pregnancy. Emergent surgery should proceed as quickly as possible, regardless of the gestational age. Truly elective surgery should be postponed until after delivery. For urgent but not emergent surgery, the timing of surgery should balance fetal safety and viability against maternal risk of continuing pregnancy or delaying surgery. Ideally, the optimal time for surgery is the second trimester, considering the first trimester has fetal organogenesis and has the greatest teratogenicity risk, and the third trimester has the increased risk of preterm labor and increased effects of hypotension by the uterus. Beyond 24 to 26 weeks, the fetus will be considered viable, and consultation between neurosurgery, anesthesia, and the obstetric teams will be essential. In later pregnancy, it is actually feasible to deliver the fetus by cesarean section prior to proceeding with a neurosurgical procedure. Perioperative fetal heart rate monitoring. The degree of fetal heart rate monitoring will depend on the gestational age, fetal viability, and institutional factors. Less than 22 to 24 weeks is considered pre-viable, and FHR will be assessed preoperatively and postoperatively only. Viable gestational ages, so more than 24 weeks, the assessment will occur pre- and post-op at the minimum. You would monitor before and after surgery to rule out uterine contractions and labor. And then, if possible, continuous intraoperative fetal heart monitoring may be indicated if physically possible to perform during the surgery, if there's a provider available to monitor and assess the fetal heart rate changes during the surgery, and if there's feasibility of an emergent cesarean section if indicated. And also, a provider with obstetric surgical privileges must also be immediately available. And the patient must have provided informed consent to an emergency cesarean section beforehand. Normal fetal heart rate variability may be attenuated by anesthetic agents, but frequent decelerations or a sustained bradycardia are indicative of fetal compromise. The anesthesiologist should take measures to improve uterine perfusion pressures or oxygen delivery to the fetus in response to a non-reassuring fetal heart rate. So, in conclusion, neurosurgical procedures, which include craniotomies, interventional radiological treatments, as well as spine surgeries, are sometimes indicated during pregnancy. Emergent cases should never be delayed, and anesthesia providers should be familiar with the physiological alterations that are associated with pregnancy to provide the safest care to the patient and the developing fetus. In non-emergent cases, the timing of neurosurgery should be discussed between the obstetric, neurosurgical, and anesthesia teams to balance the fetal and the maternal risks. The maintenance of the adequate maternal oxygenation, ventilation, and hemodynamics will be essential to ensure placental perfusion and should be a primary goal of the anesthesia provider when taking care of a pregnant patient for a neuroanesthetic.